Good evening, everyone. Welcome back to my Vivences. I hope you had a good weekend and are here to learn a bit more and find out, of course, some more details on recurrent implantation failure, as this is our topic tonight. But also, as you know, we are here also to hear some of your questions. And we have a special guest, Dr. Elias Tsakos, is with us once again. I'm very happy to have you back with us. It's always great to have you as an our expert, as you know it. Of course, you've been with us many times. So welcome back, Dr. Tsakos. How are you feeling? I hope you are feeling well and ready to help us out with some of the questions, right?
Yes, I'm absolutely fine. Thank you so much. Thank you again for the invitation. It's always a great pleasure to present some of my evidence and some of my experience on various topics, and I'm very privileged to be part of the panel of experts in the European Fertility Society.
Thank you so much indeed. And tonight we will do it a bit differently. Dr. Tsakos will present us some of the cases. He will talk from his heart. And I know that he always brings lots and lots of inspiring cases, but also has amazing advice. So I'm sure you will find it useful. But remember, we are also here to answer some of your questions. So all you need to do is just type those in the chat section. Dr. Tsakos will answer them for you right after his speech. So don't hesitate. It's all anonymous. It's your time to simply get some more advice, perhaps, and possibly get some more also courage to go ahead with your treatment. Of course, those are not easy topics indeed. So I'm glad that we are here to help you in any way we can. So yeah, that is it from me at this point. Of course, I'm your host, Caroline, and now I will leave it to Dr. Tsakos. Let me just add, if someone haven't been here before, Dr. Tsakos is a medical director at EmbryoClinic, located in Thessaloniki in Greece. So we are connected right now with Thessaloniki. So very happy, and off you go. Okay, Dr. Tsakos.
Okay, thanks again for the introduction. So I will not spend any time. I will just move on with the subject. The subject today is the recurrent implantation failures. Now, I will try to be as simple as possible. I will give a talk for about 20-25 minutes with some of my cases that I remember, and they were quite striking. And I hope those cases would be a good example of what the causes and the possible management of recurrent implantation failure may be. And then following this, I will give you a small outline of the subject of recurrent implantation failures. And then, of course, I would be very happy to answer specific questions on the topic, if possible. So I start with a definition. I mean, we use this term, but sometimes we use it without exactly explaining what it means and where it applies to. So recurrent implantation failure, by definition, is the failure of IVF. So you can't have an implantation unless you have artificial treatments, and this is by means of IVF or ICSI. So the definition, the most widely accepted definition of RIF, recurrent implantation failure, is failure after implanting after three attempts at implantation of top quality embryos. So I think most of us would agree that this is the definition. So in other words, failed IVF at an early stage, failed IVF at the stage in which we have a starting pregnancy, but this pregnancy doesn't move on to become a viable pregnancy. It doesn't produce a healthy child. And again, the failure could either be in the biochemical phase, so it could either be at the stage where the pregnancy is only identified via the HCG, by the hormone test, the hormone pregnancy test, the beta HCG, or it could be a clinical miscarriage. And again, of course, there's a huge overlap between the definitions and between what is classified as biochemical and what isn't. So, however, we have to agree that following 3 attempts of IVF with good quality embryos, if there is an implantation failure, then we need to investigate further. So this is a definition, failed IVF at an early stage. Now, I will share with you 3 cases. One is a case that I remember very vividly. She was a lady in her early 40s. with multiple implantation failures, with multiple biochemical pregnancies following IVF, and multiple early miscarriages, clinical pregnancies following IVF in an unexplained manner. So I reviewed the notes, as I do. I mean, even before the lockdowns, I used to offer, and I still do, I offer online consultations. So I provide with second opinions. Patients from all over the world can send me details, the whole file of medical notes, and I try to identify and unravel the mystery of possible diagnosis that has been missed. So I remember that case very vividly, because it was a huge case, huge file, lots of IVFs, lots of protocols, lots of blood results, lots of investigations. I still remember a very nice view, a longitudinal view of a uterus scan where everything looked normal and so forth. So to cut the long story short, I could not identify from the notes what was going on. In fact, the lady moved on to egg donation as well, because she was early, and all that before she came to our clinic. Because she was in her early 40s, it was thought that maybe the miscarriages were due to chromosomal anomalies associated with her age. And although she never had a karyotype of the couple, or she never had a karyotype analysis of the products of conception, and she never had PGTA, it was thought that maybe it's associated with the ovarian quality, associated with her age. So she had moved on. She even had implantation failures with egg donation. So when she arrived to us, she had about 7 failed IVFs. 2 of them were completely failed, and 5 had early miscarriages. And all the investigations looked normal. Now, again, depends on how we define all. I mean, what I have to clear with you is that under no circumstances can we ever be sure that we've done everything. I mean, I have patients, especially from the US or Australia, where people tend to be over-investigated, who come to me and say, well, doctor, do everything. I would like everything to be done. And I have to be very clear here. At no given point can we claim that we've done everything. I mean, there's always a little bit missing somewhere. So again, the patient came over. So I thought I would start over again, trying to investigate from the beginning a few very solid possible factors for that failure. And to be honest, to my surprise, because I was very worried whether I would find something or not, and whether I would have to offer them something new or not. Even on the first visit on the scan, when I took a transverse section of her uterus, I just identified a huge uterine diaphragm that had been missed. So the first case was a case of a uterine diaphragm. Now, uterine diaphragms are congenital anomalies. Women are born with them. They cause no symptoms whatsoever. They can have no effect on the period, on menstruation, on the cycle, on the sexual activity. They produce no pain. And if they're missed, they're missed. And they present just with either miscarriages or implantation failures. I mean, what was really interesting in that case was that this lady had a fairly big uterine diaphragm, and that was also associated with the vaginal diaphragm as well. So she had quite a big genetic disorder, congenital disorder, and that was picked up on the scan. The diaphragm was operated on. Actually, I personally performed the hysteroscopy in my unit successfully. So we created a very nice and roomy uterus. In actual fact, I divided the vaginal diaphragm as well. We did an ultrasound scan to ensure that the urinary tract was in good shape, because sometimes there's associated anomalies with the urinary system as well, and that was thankfully normal. And then the lady went on, and she had egg donation. She was successful first time and delivered a healthy baby. So that was the first case I wanted to share with you. So please, I know you're not doctors, I know you're patients. I know that the vast majority, if not virtually each one of us, we're checking the uterus on a transverse plane as well. Sometimes, yes, it can be missed. Sometimes if there's a uterine diaphragm which is not exactly central, and perhaps if there's one of the two cavities, if it's fairly normal, maybe in a lady with a fairly large body frame, it can be missed. So I urge my colleagues and I urge my patients to ensure and ask specifically if there's any possible chance of a congenital anomaly of the uterus. Now, because scanning cannot be 100%, I mean, obviously in a big diaphragm, we can pick that up on scanning quite easily. I generally insist on my patients undergoing some sort of imaging of the uterus as well, either in the form of an HSG or hysteroscopy or both. So that's the take-home message. Make sure before you start digging in deep into rare factors like immunology or killer cells or implantation windows or sort of phospholipid syndromes and so forth, please make sure that the uterus has been checked properly and it is normal. So that's my first case. The second case is still a UK patient who'd had multiple implantation failures. And again, to cut the long story short, that was associated with hydrosalpingosis. So she had bilateral hydrosalpinx. Hydrosalpinx is a situation, is a condition in which the tubes are damaged, usually through infection. Usually this is asymptomatic, so there's no indication of that disease, of that problem. There's nothing in the history to indicate that this woman has hydrosalpinges. Sometimes hydrosalpinges, if they're big, they're picked up by scan, but even big hydrosalpinges may not be picked up on scan. And the only way to be picked up is by a formal HSG again. So that was a lady who'd had multiple IVF failures, multiple implantation failures, and associated with bilateral hydrosalpinges. So that lady underwent salpingectomy in England, and then she came back to us and she had successful IVFs on 2 separate occasions. So she produced 2 healthy infants of 2 to 3 years apart. So remember your tubes. So take-home message from the first 2 cases is remember the basis of the pregnancy and the importance of the environment of the uterus and the tubes. There is a misconception that the tubes are not important in IVF. Indeed, they're not important as long as they're not hydrosalpinges. If they are, a hydrosalpinx, accumulation of fluid and toxins within the tube, may be associated with both implantation failure, miscarriage, ectopic pregnancy, and so forth. And apart from that, it could be a source of infection, which can produce problems in the woman at a later stage, even if this is not very obvious in IVF or in pregnancy. I think most of us practicing laparoscopists, we've all operated on women even in the late 40s or 50s after the reproductive period has finished with pelvic infection secondary to hydrosalpinx. So apart from the effect on fertility, a hydrosalpinx should be ruled out and should be treated by salpingectomy for the sake of the good health of our women. So that was the second case. The third case I will share with you is also a very interesting case, in my opinion. Is a case of similar complexity, lots of failed implantations, fresh cycles, frozen cycles, own eggs, donor eggs, and there was something going on. So again, I viewed the notes, and to be honest, there was absolutely nothing to point me in the right direction. I reviewed the investigations. The lady had very thorough uterine checks with scans, with 3D scans, with HSGs, with hysteroscopies, with a laparoscopy to exclude endometriosis. She'd had all sorts of biochemical testing, hormonal testing, infection testing, ERA testing. The man had extensive investigation with DNA fragmentation index. Everything looked absolutely normal. Karyotype on both the couple, genetics on the embryo, and everything looked normal. The embryos looked absolutely fine on the photographs that were provided from the previous units, and indeed there was no obvious reason. So I remember that case took me quite a few hours. I mean, it's like the investigators trying to identify factors. I mean, the lady flew over. We did thorough exams. We repeated some tests, trying to identify any factors that perhaps may have been missed on the first test. We even went on repeating some thrombophilia testing, and there was nothing. There was nothing we could identify. And eventually, I had to look at the protocol. I had to look at the implantation protocol. I mean, what we have to remember is that there's at least 100 points where a protocol can go wrong, in the stimulation, in the trigger, in how we fluctuate the hormones, in the times that we administer the drugs, in the times that we do the egg collection, in the times that we allow the culture of the embryo after thawing, before thawing, and of course in the technique of embryo transfer. It is a common secret amongst all of us that each one of us has a different success rate on embryo transfer. That's why we tend to let the most senior person in the unit performing the embryo transfers, especially in difficult cases. So everything looked absolutely fine. And again, to stop your agony here, identified an issue in the administration of progesterone. I mean, this lady was having, in the first few cycles, it had day 3 transfers. So on the frozen embryo transfer, the progesterone was administered in line with the implantation window associated with day 3 transfer. And for some reason, that protocol had been copied on for the later transfers that had been blastocyst transfers. So in the first few cases, in the first few attempts, she'd had an embryo transfer of questionable quality embryos because there were day 3 embryos, but with good protocol in line with day 3 implantation. And then on the day 5 embryo implantations, she was given 2 days less progesterone that she should have been given. So the endometrium was day 3 for day 3 transfer, and she'd had day 5 transfers. In my opinion, that was a critical issue. I addressed that to the patient, diplomatically, and we corrected that. And to be honest, we used the same embryos. We never created embryos. We just changed the protocol, and the lady got pregnant successfully. So again, this is a very fine example of the importance of the finest detail in the management of our patients. And this is another example of how important it is for patients to be empowered by knowledge. And please, we ask you to challenge us, challenge every decision we make, challenge every step we make. And it is one of the promises I've made over the years. Hopefully with very simple forms of artificial intelligence, we can very soon have software to patient-controlled software, so that they can have the control of their own treatment on very basic stuff. I mean, the progesterone. I mean, we're having lots of conferences discussing the value of various drugs, of stimulation, the value of different routes of administration of various protocols, and then we can just fail because we don't give the progesterone long enough, or we don't start it on the right day. So these are my 3 cases. Please allow me 5 minutes to give you an overview of the recurrent implantation failure subject. So the reasons for that The reasons for recurrent IVF failure could be either uterine or, let's say, environmental. They could be male factors, they could be embryo factors, they could be genetics, and it could be the protocols we use. So make sure we ensure that the environment of implantation is normal. As a simple rule, I always request a very high definition ultrasound scan of the internal organs of the female, and usually this coupled with some sort of imaging. I'm a big fan of hysterosalpingography because I still feel, although it's a little bit of an old-fashioned technique, but it's giving us a good second opinion, if you like, on our scanning diagnosis, and that usually coupled with a hysteroscopy. I don't perform laparoscopies very often, although there is some evidence that maybe there may be some factors which can be identified by laparoscopy. They could implicate the IVF. However, laparoscopy is an operative procedure, so I don't perform many diagnostic laparoscopies, but hysteroscopy, in my opinion, is part of the baseline investigation, and of course, it's even more valuable in recurrent miscarriages. I'm looking out for congenital anomalies of the uterus. I'm looking out for polyps, myomas, adhesions, evidence of infection, and I like to ensure that the uterus has been thoroughly checked at least 2 to 3 months before the implantation. Now, other factors include thrombophilia. Again, this is a huge chapter that I'm not going to go into it. There is some evidence that there may be association between antiphospholipid syndrome, thrombophilia, and recurrent failure. So I keep that in mind. Male factors need to be investigated, in my opinion, although with the use of ICSI, we can ensure to a big extent that we pick up the top quality sperms. Now there's new technology coming out helping us to identify the best quality sperm. The embryo quality is also very important. Certainly the culture media, the culture techniques, the culture technology has improved over the years. It's just like our phones. If you want to have an idea, if you would like to have an idea of what an IVF lab looked like 30 years ago when I started my IVF, just look at the phone, at the telephone that we used 30 years ago compared to a current one, or look at the car 30 years old and the new car. So that would give you an indication of how much the technology has also evolved in the IVF lab. Having said that, the human factor is also important. There's still the human factor in performing the ICSI. We don't do robotic ICSI yet, although I won't be surprised if we end up doing it at some stage. So we still need the highly skilled laboratory colleagues, not only to perform the techniques, but also to ensure that the environment of the lab is perfect, the environment of the media is perfect, the loading of the needle is perfect, the embryo transfer is done perfectly in a uterus that has been prepared perfectly with the largest possible attention to detail. And again, look at the protocols. We like to put some add-ons on the protocol. To be honest with you, although the evidence is not brilliant, with recurrent implantation failures, I generally suggest the addition of aspirin and low molecular heparin. This is again a long discussion. In my opinion, these are very cheap drugs with no major side effects, and maybe in a small proportion of cases they may be helpful, especially when we have some question marks with regards to immunology and other factors. And of course, finally, make sure there's no infection there. There's a lot of high-tech ways to check for infection. So let's make sure that the environment does not contain any infective factors. And even so, I wouldn't disagree with some of my colleagues, and actually myself sometimes I do use empirical antibiotics prior to the implantation. Finally, what I would like to share with you is that patients with recurrent implantation failure are the most valuable patients we have. are the patients in which we test our trust, our connection, our openness, and our understanding. For me, not only are they the most challenging cases, but they're also the cases in which my trust is challenged, my medical knowledge is challenged, and I would like to personally thank all my patients who failed multiple times with us, and who kept on coming, kept on trying, kept on working with us, kept on hoping with us, and gave us the strength to give them a little bit extra next time. And I'm very grateful to them. And in particular, I have a darling patient. This is Emily. Thank you so much. After so many failures with us, you kept trying, you kept your faith, and now, thank God, you're a few weeks pregnant, and let's hope that this pregnancy will go on to term. So thank you all for listening, and I'm open to questions. I may not be able to answer them all, because unfortunately in this complex issue there's a lot of question marks, but I will try my very best to give you the best possible answer. So please fire away.
Thank you so much indeed, Dr. Tsakos. As always, it's brilliant to have you here with us. You always have great advice and bring so much hope, for sure. So thank you so much indeed. And you are very right. There are plenty of questions. So let's go ahead with those. And as Dr. Tsakos said, we will not be able to answer all of them tonight, but don't worry. I always will forward this. The unanswered questions will be forwarded to EmbryoClinic team, and I'm sure they will be happy to get back to you. Okay. Thank you so much. And now let's go ahead. As you can see, plenty of questions are right here. Let me go with the first one, which is a bit of a longer question. So I'm currently doing embryo banking at a clinic abroad. I'm 41, have 2 frozen embryos when I was 40. Next year, we will proceed with the transfer. I have a small endometrial polyp measuring around 5 millimeters. Do you recommend removing it before transfer, or is it not necessary? Also, I want to ask if there is any risk when doing repeated stimulation cycles. I have a family history of breast cancer and was wondering about the risk these hormones entail if taken repeatedly. Thank you so much for sharing as well, of course.
Sure. Hi, Christina. Thank you for the question. And firstly, yes, keep banking embryos, but just make sure that these are good quality blastocysts. So I would encourage that. Now, when do we feel that we're confident with the outcome? The question is, in your age, we would need a good number of embryos. And again, depends on whether these embryos are PGTA tested or not. So keep storing. And on the other hand, do not delay the embryo transfer too much, because although the success rate is, of course, depending on the quality of the blastocysts, so please insist on banking day 5 embryos. I mean, I wouldn't like so much having the illusion of day 3 embryos at your age. But even with blastocysts, unless we've done pre-genetic screening, we're not sure of the quality of the blastocysts. And unfortunately, the rate of abnormality, chromosomal anomaly, DNA anomaly of the embryos in your age could be as high as 50 or 60%. Now, with regards to the polyp, absolutely yes, please go ahead and remove it is my advice, but please do it maybe soon before you do the embryo transfer, but don't delay it too much, because we're always a little bit worried about polyps in women over the age of 40. Although the chance of malignancy, the chance of cancer is extremely low, it is not zero. So it is not just for reproductive reasons, but it's also for your own health that I would strongly suggest you have a hysteroscopy. Now, with regards to family history, my team and I are very sensitive, I think, like most teams, on breast cancer. We're a little bit more sensitive, perhaps because we have a breast physician in our team, and we always demand, it's one of our not suggested tests, but obligatory tests, to have a formal breast assessment prior to IVF. That breast specialist in our team happens to be my wife, and she has threatened to divorce me if she ever found out that we did IVF on anyone without a formal breast assessment. Now, I'm also very sensitive about breast cancer because I lost my mother to breast cancer, and this is the reason why I became a doctor. Unfortunately, breast cancer is very, very, very common. The rate in the Western societies could be as high as 1 in 7, 1 in 8 women. Whether it's associated with IVF or not, there's good evidence now to suggest that there's no association. In other words, IVF treatment does not cause, there's no causative association, doesn't cause breast cancer. However, if someone has a small lump and that lump is undiagnosed, and if that person undergoes IVF, this lump will grow, and not only will it grow, but it will also remain undetected during pregnancy and breastfeeding. I'm very sad to share with you the fact that in my unit we pick up 2 to 3 cases of breast cancer prior to IVF through our screening program. So now family history, so please have a very thorough breast exam. I know I'm very familiar with the guidelines in different countries for breast screening. I'm not happy with that. I know that the European scenario is that in the majority of the European countries, official breast screening offered free doesn't start before the age of 40 or before the age of 45 in some countries. That doesn't mean that this is justifiable, because unfortunately a good percentage, if I remember the figures correctly, it's about 50% of breast cancers, they occur in women under the age of 40. So although our countries have decided that maybe this risk is small, for our patient, the individual patient, this risk is very big. So please, all of you listening, make sure that part of your baseline fertility workup investigation prior to touching one single injection of stimulating hormone or of estrogen tablet, make sure you have your breasts properly checked. And when I say properly, I mean by means of either mammography or ultrasound or both. Breast self-examination, even medical examination, clinical examination of breasts would not be reassuring enough before starting IVF. Now, this is our protocol anyway. Now, breast cancer in the families and family history. Again, this is a very long discussion. However, to relieve most of you, now the definition of family history of breast cancer is if you have 1 or 2 relatives who develop breast cancer at a younger age, younger than the age of 50 or 45. And the majority of breast cancers are not genetically linked. So in other words, they're not associated with the genetics, the BRCA gene, which is associated with high-risk breast cancer. So please have your own doctor to give you your own assessment, risk assessment. So a granny who developed breast cancer, your granny or your auntie at the age of 60, they do not count as family history. Having said that, please have formal assessment of your risk for breast cancer based on your family history, of course, on other associated factors like alcohol and smoking, on previous possible issues on breasts, and please make sure that you have a fresh, recent, current, accurate breast assessment prior to embarking on IVF.
Thank you so much indeed for a great question indeed, and Dr. Tsakos for your advice. I would thank you that we were able to also discuss this. This is definitely an important thing that we need to remember about. So thank you so much. And as you can see, Christina also would like to thank you for your help and answer. And let's have a look. Carolyn has another question. So what is your opinion about endometrial scratch? If you believe it has a role to play increasing implantation chances, how would you include it in a cycle, and how long before transfer?
Sure. Endometrial scratch was very popular until some years ago, a couple of years ago, when some evidence showed that maybe it's not associated so much with success. However, I like it, to be honest. I mean, I think it's an opportunity to get some more information about the uterus. And I usually, to be honest, on women over 40, I invariably suggest a hysteroscopy and endometrial biopsy before IVF. In women under 40 and women with absolutely normal scanning, high quality scanning with no previous history of miscarriages and with no risk factors of endometrial pathology, I would not do a hysteroscopy. I would not suggest hysteroscopy. However, with women with recurrent implantation failure, I would very much like to have a first hysteroscopy at least minimum of 6 months prior to another implantation. Now, scratching could be performed either together with hysteroscopy, or it could be performed with independently of hysteroscopy by means of a pupil biopsy. In either case, I think it's an add-on which may give us some more information. So in general, although I don't expect miracles from it, I generally wish to have some evidence from the endometrium, and of course the substance we remove from the endometrium, I would like it to be checked both histologically, and I would like an infection test on it. I would like to share with you a case, a recent case, a 2021 case of a lady in her early 40s. She's only 41, 42. 2 implantation failures, small fibroid, 30 centimeters, not so much touching onto the cavity. Done a hysteroscopy, mainly normal endometrium on the scans. Done a hysteroscopy mainly to ensure that the fibroid was not distorting the endometrial cavity. The cavity looked fairly normal. Took a biopsy, and the biopsy showed sarcoma, malignant sarcoma, which is a very, very dangerous type of uterine cancer. I mean, the lady went on and had a hysterectomy, and that confirmed the diagnosis. She moved on to surrogacy after that, and that lady had her life saved, basically, because we did that. And when, of course, it's a rare case. It's a case report, actually. We're going to present it soon. Thankfully, it's very uncommon. However, it does give us the importance of having some sort of tissue. I mean, the women we're dealing with are more often than not over 38, 40 years old. So the chance of pathology, uterine pathology, is fairly high, and especially women with recurrent implantation failure.
Thank you so much indeed, once again, of course, for your help. And there's an answer. And an additional question, let's have a look. Thank you for your answer. In place of hysteroscopy, would a saline sonogram work?
Yes, the answer is yes. However, the diagnostic accuracy is less compared to the hysteroscopy. I mean, a saline sonogram is still ultrasound imaging of high quality. So this cannot replace by any means the direct visualization of the uterus, and also it cannot replace the value of having a tissue biopsy.
All right, of course. Thanks so much, and understood from Caroline here for you as well. Okay, let's have a look at the next question. In my country, we do not have access to ERA. How else can we determine if we are in the right implantation window? Is there a minimum number of hours of progesterone intake before blastocyst transfer?
Sure. Just to relax you, Caroline, neither do we in Greece. And to be honest, in my practice, I don't use it at all. Why? Because I'm not convinced with the evidence so far. Designing the protocol is an art, and of course that has to do with the quality of the embryos, the stage of the embryos. Sometimes, yes, the hours are important. The type of progesterone we use is important. The type of estrogen we use is important. How we monitor that is important in terms of both the effect on the endometrium, and also do we do hormonal tests? Do we check to ensure that there's no progesterone rise before we start counting the progesterone days and all that? So there's a lot of little hidden mysteries there. In general terms, put it this way, we can either do a fresh or a frozen cycle embryo transfer. So in the first embryo transfer, I am very particular about the progesterone levels. I like the progesterone levels to be low. I measure progesterone quite frequently, and I become a little bit nervous when progesterone before the trigger is higher than one nanogram. So, this is something to remember. I always perform progesterone levels on the day of the egg collection as well, and there is a correlation between the trigger progesterone levels and the OPU day, the egg collection day progesterone levels, which I try to correlate. And then, of course, if I'm considering a first embryo transfer, I need to make sure, and I need to be sure that I'm happy with the progesterone levels being low enough and not even being anywhere close to the gray zone. Why? Because I understand that there's the accuracy of our assays and our measurements is not brilliant for progesterone at those low levels. So I need to be sure that I'm very happy with low progesterone, and if that's the case, then I move on to first embryo transfer as long as I have also good ultrasonic appearance of the endometrium. Now, if I'm in doubt, of course, I do freezing. Again, the decision of freezing also depends on other factors like the quality of the embryos, like other factor includes, do I have one embryo transfer altogether or two? So, for example, if I have one precious embryo, perhaps I would save it for a frozen embryo transfer, where I would feel more confident that the progesterone would be lower. Now, on a frozen embryo transfer, again, there's a lot of ways to do the protocols. Many people don't do downregulation, and in 90% of cases, they're right. However, in my practice, I invariably I perform downregulation with a single depot injection of GnRH analog prior to a frozen embryo transfer. If I decide on a medicated cycle, sometimes I choose a natural cycle, and always I measure very carefully the hormones, not just the progesterone, but also estrogen and LH, trying to correlate and trying to understand as closely as possible when the implantation window is going to be. In general, for blastocyst transfers, I like to have 5 days of full progesterone, but it's not just the progesterone, it's the how we administer it, and of course, how good is the environment of estrogens that we add progesterone onto. So that's a little lecture on my protocol.
Thank you so much indeed, of course, again for this. And another thank you coming up here. And let's have a look. Of course, there are plenty of more questions right here. Let's have a look at the next that we have. So, does implantation failure get worse with age? After how many attempts should you stop? Is PGS testing worth it?
Yeah, sure. I mean, age is one of the factors associated with implantation failure. And of course, when it comes to age, there's two elements. One is the age of the oocytes, and the other is the age of the carrier. And they could both have an effect. And of course, they could both have an effect. And the biggest effect is of course, the oocyte age. So age is important, and so is obesity, so is smoking, so is stress. So any lifestyle factors may also affect implantation. Let's remember that. And smoking, male smoking and female smoking could be equally important. So please watch out, smokers. So after how many attempts should you stop? Okay, basically, let's take the scenario that someone is between 40 and 45, which is the commonest age group for implantation failures, and they're using their own eggs. To be honest, I would encourage, after 2 or 3 implantation failures, I would encourage the use of PGS, definitely. Why? Because chromosomal DNA anomaly is one of the major factors of implantation failure in that age group, and by PGS testing those embryos, at least I avoid the question mark of the possible reasons of failure. So this is a take-home message. Over the age of 40, I have very low threshold in performing PGS. By doing so, I know that I have eliminated at least one important factor. Now, if someone is producing PGS normal embryos and up until the age of 45, and if all the other factors that we can perhaps think of are normal, I would keep going. There's no reason why you should stop. In theory, a PGS euploid embryo could produce a healthy child. So medically, you could keep going. And again, of course, depends on how you feel about egg donation, how you feel about IVF altogether, how much support you have from your partner, from your environment, and so forth, from your clinic, and how quickly do you want to become a mother? Because of course, this is not a very quick way. So if you feel tired that you've spent a lot of years, and if you really want to get there and shorten the time to pregnancy, then perhaps you should consider stopping. And of course, the option would be to use egg donation. And with egg donation, the tables are turned. So the chance of success, provided everything else is normal, provided sperm is fairly normal, the man is of fairly decent age, and you don't have any serious associated factors, you could be talking of a success rate of up to 70% per cycle and more than 90% per cumulative pregnancy rate per egg donation cycle. So when to stop is something very personal, and you would need the advice of your team, of course, and the support of your family members in order to reach that decision. Also, geography plays a role. I mean, if you have a clinic down the road, I mean, I have patients who walk into my clinic from the neighborhood. So we do natural cycles every month for many months. And if the cycle is not good, we cancel and they go to work and then they come the next month and so forth. So there's a lot of factors to take into account. But again, by all means, I would highly suggest PGS testing of embryos over the age of 40, especially with IVF failure history.
Understood, of course, as well. And Claire, I would like to thank you for that. And actually, there is a follow-up, from a different patient. So related to the implantation failure with donor eggs, is it worth PGS testing, of course?
In my opinion, no. That's my clear answer. No, because the chance of identifying it, provided sperm is normal, provided that the male has normal karyotype, and there's no reason to suspect any sort of male chromosomal anomaly. So if the male is normal and we're using a young donor under the age of 30, the chance of chromosomal anomaly on the embryo is extremely small, and in my opinion, it's not worth PGS testing that. And scientifically, the value of PGS increases over the age of 35. However, with egg donation cycles, because miscarriages do happen, the overall chance of miscarriage in my unit with egg donation is in the region of 10 to 15%, which is fairly low if you think that we're talking about women over the age of 40, where the natural pregnancy or the oocyte miscarriage rate could be as high as 50 or 60%. So there's still miscarriage rates, so we need to eliminate the other factors I was talking about before, the uterine factors, male factors, environment factors, thrombophilia, infections, and so forth.
Thank you, indeed. Again, and perhaps you can have a look at this and advice. So when do you suggest uterine surrogacy after many recurrent implantation failures without a known factor?
Yes. Well, again, surrogacy is the end point. So with surrogacy, anyone can get pregnant because, as we all know, they don't need the uterus, they don't need the sperm, they don't need the ovaries, they don't need the oocytes. So in surrogacy, we can use foreign genetic material and we can create families. And I think this is an absolute miracle. However, I reserve surrogacy for cases of recurrent implantation failure where we've used egg donation. So I would like to exhaust. I mean, I have a lot of patients coming to us for surrogacy who haven't tried egg donation, who've had multiple IVF failures in the early or mid-40s or late 40s, and they feel that surrogacy is the way forward without even trying carrying a child through egg donation themselves. The way to surrogacy in this pyramid is, after trying your own eggs, try egg donation. Make sure you optimize all the factors that could affect a healthy pregnancy. So make sure your uterus is very well checked. Make sure you have all thorough tests of your biochemistry, your hormonals, your infections. The male is tested. We have karyotype, we have cystic fibrosis, we have DFI. We've done all the alterations, the lifestyle alterations that could be associated with better results. To be honest, I think there's a very small proportion, maybe 5% of women who fail when everything else is normal after 2 or 3 egg donation attempts. So for that 5%, maybe I would then consider embryo donation, because some of these women may produce, some of those couples may produce embryos of questionable quality due to male factors. So then I would use double donation, embryo donation, and even if that failed, this is the time in which I would probably move on to surrogacy, or I would move on to surrogacy if there are limiting factors in the uterus. So if someone has multiple fibroids or huge adenomyosis or adhesions, we hate adhesions in the uterus because there's very little we can do at the moment to treat them. If they've had multiple DNCs, multiple operations on the uterus, and so forth, yes, then I would move on to surrogacy quicker. But as long as a female under the age of 50 has a fairly healthy uterus and a fairly healthy endometrium, and they're willing to use egg donation or sperm donation or both, there's a very small proportion of those patients, less than 5%, that would need surrogacy.
Thank you so much, of course, for that honest advice as well. And thank you for an interesting question. And as you know, we will be slowly finishing. Okay, so that might be our final question. It is a bit of a longer question, so let's go ahead with that. I'm 46. We've done 9 rounds of IVF, own egg, own sperm. From this, had implantation once when I was 39, but this ended in miscarriage. Since then, we moved to egg donor, own sperm. From this, we got 6 good quality embryos, but all failed to implant. I have hysteroscopy, aquascan, basic immune testing, sperm DNA testing, etc. All okay with no major issues before embarking on our next egg donor round. What would you suggest?
Yeah, well, you're one of those cases that I presented, I'm afraid. I would probably need to have a look at your notes. I mean, if you don't mind, you can email my coordinators on info@embryoclinic.eu and send over your big files. I would be delighted to make a cup of tea and study them, and hopefully I should be able to help.
Of course, thank you so much indeed. I do understand that you definitely need more and details about this case to be able to help out. So as Dr. Tsakos said, okay, go ahead, email Dr. Tsakos and his team, and they will be happy to help you out, I am sure. Okay, so there are like 3 minutes, okay, Dr. Tsakos, let's have a look at the final question for us, okay?
Yeah.
Great. Let's have a look. Here it is. Today I had a collection in the UK. I'm 39. We have had 2 failed cycles. My question is what to do or ask to ensure the best possible transfer this time. If we are lucky enough to have day 5 blastocysts, what can I do to improve chances of implantation?
Right. Okay. I will give you some simple advice. I mean, try to improve your lifestyle factors. So smoking, alcohol, exercise, diet, stress. So those 5 factors, please optimize them. Secondly, try to create blastocysts, and try to have the most experienced person on the team do the embryo transfer for you. And I think that's it. Day 5 blastocysts, they need 5 days of progesterone. Follow your advice, have a look at the protocol, and hopefully you will make it. I mean, 39, if you produce maybe 3 or 4 good quality blastocysts, you have a good chance of success. So go for it.
Thanks so much, of course. Once again, thank you all actually for all of your questions. I know there are so many questions left. As I mentioned, it will be forwarded to the team at EmbryoClinic and Dr. Tsakos. And already I know that the previous the previous patient already said that they will send an email to your coordinator to get some more details. So, you can just do the same and get some more details from Dr. Tsakos. And I just want to add that, as you can see, Dr. Tsakos, there are some comments. As always, it is always a pleasure to hear your advice in IVF procedure and how to avoid possible problems. What can I say more to this? Of course, there are always amazing comments from you. So thank you so much indeed, everyone, for joining. I do believe it has been useful. Dr. Tsakos, as always, before we finish, anything else you would like to add?
Sure. I would like to thank everyone for the interaction. I must admit I've learned a lot from my patients over the 30 years that I'm practicing. And what I've also learned is that if you really want something, you can achieve it. So keep trying. Don't give up. Keep empowering yourselves with knowledge. I hope we gave you some tips today. My team and I are available to support any patients either live or online. The pandemic has given us this opportunity. Now we feel much more confident and familiar with the online system, online consultations. Today I was talking to patients from Singapore, Malaysia, Canada, the US, and also from down the road from a lady who was looking after an elderly relative. So it's quite an interesting way to interact with patients on the platforms. Thank you, the European Fertility Society, for this opportunity. Thank you, Caroline, for being our host for, over 2 years now. And thank you for the invitation, and looking forward to our next event. Lovely
Definitely.
talking to all of you tonight.
Thank you so much. Indeed, you know it, anytime, any day, and I'll be happy to cooperate with you. So thanks so much as always. And of course, thank you everyone for joining. As you know, we wouldn't be here without you. So thank you for coming. Thank you for your questions. And we will continue to support you. So go ahead, sign up. There are more events coming up. Of course, we will be back tomorrow. Dr. Tsakos always also will be back. So just stay tuned with us. And of course, have a lovely and peaceful evening. And I do hope to see you soon. Fingers crossed for all of you, as always. Thanks so much. Good night, everyone. Bye.
Bye. Bye-bye. Thank you.